um, our training series. I'm Matt White, joined by Andrea White and our friends at Rhode Island Housing. Um, Many of you have been with us throughout the whole series of trainings, so it's always good to have some familiar faces. As you're able to come off camera and ask questions or make comments, those are always welcome. Today, we're going to be focusing on a topic that has actually come up. It's been sort of bubbling up throughout all of our trainings. The techniques and strategies for case management that we've been talking about can become especially challenging when you're also layering on top of general case management the sort of behaviors of people who are struggling with some kind of mental illness, substance use disorder. So today we thought we would focus explicitly on some of those high acuity clients. And we're going to be talking about what are behavioral health disorders, mental illness, substance use, how they manifest themselves, and then some strategies for managing that in the case management environment. Again, I think you'll find that a lot of the topics, a lot of from these topics have been bubbling up in other trainings that we've done. But the focus for today is specifically on the behaviors. And so that's where we want to make sure that we're arming or equipping you all as case managers to both understand, to see, to identify the behaviors, and then some strategies for managing it. And as I said, always welcome questions, interruptions, comments. You can either put it in the chat if you want to come off mute and jump right in. Those are welcome as well. So with that, I'm going to go ahead and get started. So we'll talk about sort of a key kind of maybe the take-home message for today is a focus on the behavior rather than the diagnosis, and we'll explain why that maybe absolves you of some of that more kind of clinical responsibility to diagnose people and just focus on the behavior. I think it puts us all in sort of a safer space. And we'll focus specifically on mental health, mental illness, substance use disorders, the role of our first responders when we are in the midst of a crisis with our participants. As always, bringing this to life with case discussions. So we have some examples that Andrea has populated based on the breadth of experience and exposure to different kinds of challenges throughout Andrew's career. So some of those will be brought into the discussion to add a little bit more texture and color, and as an opportunity for us to kind of pick apart what is this that we're talking about in terms of high acuity clients and what are the strategies and techniques for managing that. And then, as always, we also share some resources. This is just a 90-minute sort of dip into these topics. As always, we could spend much more time, and so we want to give you some resources when you do have an opportunity to kind of dig a little bit deeper on your own, where you might go for more information or other resources. So we'll finish with those as well. So, as I said, I think a key maybe take-home message for today is that we're going to focus on the behavior and not the diagnosis. Although we're trained and hopefully get improving our skills in case management, and some of you have some clinical background, the focus is always on the behavior and not the diagnosis. In a case management or in a kind of clinical setting, there are people who are trained to do a diagnosis, clinicians who spent years in getting the licensure, the exposure, and the training and support to be able to make a diagnosis. And that can also often lead to ability to bill differently, to charge time differently, and to get people access to medications that require a clinician's prescription.
Hey,
But
Matt. One
yeah.
of the things that somebody told me is diagnosis is simply a commitment to treatment, right?
Hmm.
And it guides the treatment resources. And I want you guys to think about not only we're expecting you guys have the experience and you know what's right and what's not right, right? So let me give you an example. We had a guy who came up in a case conference and he was diagnosed as with schizophrenia. Okay. Now I want to give you some behavioral guidelines, right? There was no evidence he was hearing voices. There was no evidence he had a fixed delusion, right? He wasn't talking about that. He'd been off medication for 3 years. Does that sound like schizophrenia to you?
Yeah.
No, right? And your senses are going to go up. So what do? If you are a treatment resource, then you change the diagnosis. But as a case manager, you make the case for somebody to get reassessed, right? That's the difference. Case management is one of the most sophisticated clinical challenges you can have, and often the least resourced. And one of the things that we're trying to do is narrow down what the case management responsibility is, right? Does that make more sense? Does that make
Mhm.
sense?
So in your
We're
example,
not
Andrea,
questioning whether you guys know. I bet you do know, right? But that we don't want to get you in a position, but if medication is indicated or something else, you're not going to do that, right? Nobody here is going to. So that our job is to get them there, and our job is to recognize, right, when something doesn't feel right, but we're doing it through behavior.
Mhm.
I mean, have you ever seen somebody who has schizophrenia who's been off medication for 3 years and has no psychotic symptoms? Me neither, right?
Mhm.
So there we go.
And I think sometimes the challenge with diagnosis is that it, uh, it locks people in, or it like puts them in a box, and then that label follows them, and there's a risk of using that
That's right.
label, and that follows them continually through case management handoffs, through other engagement in other programs, and then the participant themselves start to see, well, I have a mental illness, or I have this behavioral health
Yeah.
disorder, or I have this substance use disorder. And the manifestation of the behavior on a day-to-day basis is really what, as a case manager, we're focused on. Housing stability, self-sufficiency, income stability, those are the core things that we're focused on. And if there might be a diagnosis, or there might be some history that follows this person in the chart,
Yep.
but if in the day-to-day work that they're doing, or the day-to-day operations of their life, it's not manifesting in a way, we don't want that to become like
That's right.
something that sort of they're saddled with and that follows them along. So it's sometimes not as useful to focus on the diagnosis. It's much more useful for case management purposes to focus on what are the behaviors, the daily behaviors of this individual, and how can we manage housing stability in the context of what they're exhibiting in those behaviors. So let's focus on the first example. We'll go into substance use in just a moment, but I want to talk exclusively about mental illness now. And what constitutes mental illness? What are those behaviors? And how do we focus on housing stabilization in that context? So I think, Andrea,
Yep.
we'll
I'm
shift
going to
right
pick it up
there.
here. Okay. So let's talk a little bit about mental health stuff that's coming up, right? So what counts, right? So technically, mental health conditions involve changes in emotion, thinking, behavior, or a combination. How helpful is that? Probably not real helpful, right? But the most important thing we got to pay attention to is they're associated with distress or decrease in functioning, right? So one of the things that I used to do, I mean, I came out of mental health into case management. And if somebody was psychotic and somebody had a hurty foot, I was all over the psychosis, right? They're hearing voices, blah, blah, blah. Was that their priority? No. People address things when they're either feeling distress or it's interfering with something they want. And we want to keep that in the back of our minds all the time. Severity ranges, right? Anxiety can be manageable, anxiety can't be manageable, and it changes, right? Due to circumstance, due to a bunch of different things. I'll give you an example. Somebody may hear voices, right? But they're in the shelter, and think about it. Shelters are noisy all the time, right? And they don't show a lot of symptoms. It's clear they're hearing voices, but it's not a priority for them. They get into housing, they close that door, it's quiet at night. What happens? Come on, you guys have seen this. What happens? Those voices get louder, right? And so my first reaction when I was running housing, because I'd also run a shelter, is, oh my God, the shelters lied to me. No, they didn't. It was a different, they might have, but I don't think so because it was a different circumstance. So we want to think about that all the time, right? What changes things, how things change, that sort of thing. Because as a case manager, we can address that in different ways. Mental health issues can affect anybody, right? There's all sorts of things. Do we know what the basis of mental health is? No. Is there a blood test for schizophrenia or for depression? Nope. Right? It's based on behavior. That's one of the reasons why we're focusing on behavior. And the truth is, no one wants to be mentally ill. No one. Right? So that people will fight it. And when people start to feel better, even if medication helped, they'll go off of medication. And you'll see that as people's circumstances change. Have you seen that? It's not, it's part of any kind of disease management. We have a lot of understanding when people stop taking their antibiotics, right? Because they feel better and they feel like they don't need them and they don't want to take that pill. This is no different, right? So we need to think about that because it's all going to lay the groundwork of how we're going to work with people as case managers. Okay, let's go to the next one. So what's it look like, right? Bipolar disorders. What's mania look like? People are pretty charged up, right? Oftentimes they have pressured speech. You ever talk to somebody who's talking really fast and all of a sudden your heart speeds up? Okay. My heart rate's going up and I'm feeling more anxious. Okay, I'm picking this up. Maybe this is mania. Maybe it's high anxiety. Maybe it's a lot of things, but this is something that happens. People get irritable. They're more active than usual. They have racing thoughts. Think about this. Mania also feels good. That's why cocaine is so popular, right? Mania feels good until it doesn't, right? And so people are often reluctant to give up that manic feeling. I mean, people pay a lot of money for that.
I've
People have it. Go ahead.
Oh yeah, I've talked to people who say it's like better than any drug that they've
Yeah,
ever taken. They're like, it's
yeah,
just, oof, when it's good, it's good. And if that's how it feels for people, I can understand why they don't want to give that up when they're feeling it.
that's exactly right. And you know what? Give it up when they're feeling it, and it's until it gets them in a lot of trouble, right?
Well,
Or
yeah,
until it takes them over and until they don't sleep a while, right? But that's exactly right. And the other thing is we know that there's an impulsivity that's built in living a crisis-based life, which most of the clients we have. So they can feel exactly what Sarah said in the moment, right? And so that's pretty compelling. So we need to think about that. People can increase their appetite for spending, for sex, for other pleasurable food, other pleasurable activities, and people often feel important, right? Now, how compelling is that, right? They feel important, talented, powerful, right? Until it goes wrong, right? And we know that for most people it's going to go wrong, but they can't see that. Okay. When people are depressed, they're feeling down, they're feeling sad, they're feeling anxious. There's also an agitated depression where people are very anxious and agitated, right? They could feel restless. They have trouble concentrating. They have trouble making decisions. They have sleep problems. They may slow down their cadence. Now, why do I keep talking about how people's speech affects it? Because that's one of the behaviors we're going to pay attention to. Does that put people at risk? Not necessarily, but it's a clue, right? People often feel hopeless and worthless. They may have thoughts of death or suicide. The other thing that people should be aware of is the suicidal risk increases when people start to feel better, right? So now we've integrated a couple of things. How does this feel? What's the behavior look like? And we need to think about the risks. Okay, let's go to the next one. How about psychosis? Okay, could be anything. Could be psychosis, not other with steps. Could be a lot of different diagnoses, but it's basically a break with reality. Is their thoughts and perceptions become disturbed, and it can be hard to tell what's real. You've heard us say this before. Don't argue somebody against a psychosis. What feels real to you is not going to be real to them. And that applies for a bunch of different things, the subtle and the real, right? Nobody's following you. Does that help? What I think about when somebody says nobody's following you or tries to argue with a psychosis is, if I'm upset and some member of my family or one of my friends says, yeah, you just need to get over it. Just calm down. What do I think?
They're a jerk.
They're a jerk. Exactly. Right? So as case managers, we always try not to be jerks, right? So it doesn't mean we don't talk about their feelings, right? What we can both relate to is that must be scary. How do we help you feel more safe, right? It's different from nobody is following you. We want to look at their functioning, right? These are the things that help compel people to get help. Functioning and distress, right? And we want to focus on that. We also want to be aware that when people's sense of reality gets challenged, what they think is happening gets challenged, they react to that, right? So we had somebody in one of our buildings who thought their neighbor was breaking into their apartment, right? And we tried a bunch of things. We had cameras in the hallway. We tried showing them the cameras. We tried an extra lock on their door. We tried a bunch of different things, right? But they all challenged this person's perception that they were sure of that this guy was breaking into their apartment, right? And so we tried a bunch of things and they tried a bunch of things. And the final thing they tried was they tied their neighbor's door shut, right? Which was horrifying and scary, right? Okay, so we weren't addressing this. We might have been on the right track with the lock, but we probably didn't pursue that long enough. But what our job was to help the person feel safe, right? And safe enough to make some decisions and to help them get some help for the anxiety they were feeling, right? So that was a different conversation. Is this making sense? Yes? No? Maybe? Okay.
I thought one thing that I want to make sure I heard it right. I thought you mentioned that people sort of who have a history of psychosis, when they are starting to feel better or just there's sort of a natural wane in that might put them at higher risk for self-harm, or did I mishear that when you said
Depression. Depression is
Okay.
usually, that's the one we really pay attention to. Though psychosis can put somebody at risk for self-harm, but it's usually people put themselves in risky situations people challenge people they shouldn't challenge, right?
Okay.
Um, for psychosis, it's a little different, and it's usually when people feel hopeless and that there's no, so tying the neighbor's door shut put them at real risk for not only eviction, but for the neighbor to pop them, right?
Mhm.
And the neighbor was as close to psychotic as I ever want to see him. He was so mad, right? But he wasn't psychotic. But I mean, I think that it's depression when people start to feel a little bit better, you want to watch it like a hawk, right? Doesn't mean they'll
Mhm.
necessarily be risky for self-harm, but it's a fairly common pattern that we pay a lot of attention to. Yeah. But this is people experiencing psychosis are statistically more likely to hurt themselves than anyone else, right? But they're doing it in response. There's other things that can happen. If people are hearing voices that tell them to do things, that might put people at higher risk. So it's how the psychosis evolves, right? I hate this word reality check, right? Because I think it's basically challenges people's assumptions that people don't respond well to. But you can help people gradually see how they can feel safer, which does challenge their reality, but in a gentler way and puts people in control. So that's what we're going to think. Telling people not to feel that way is probably not going to work. I mean, here's something that I always think about. If it doesn't work in my regular life, it's not going to work in my work life, right? And so, me telling my family to quit thinking that way has been not very effective. Yeah, Derek.
Yeah, so I don't have a lot of experience with this in my working life, but I do some volunteer work with the National Alliance for Mental Illness, and
Yep,
some of the techniques that they emphasize are like really trying to build like empathy in the way that you were suggesting of like showing
yep.
when you understand how they feel, and then focusing not on what they believe, but what needs to be done. So how can we work together to do like what the next step is?
Yeah, and how to make them, right? So it starts with a feeling, how to make people feel safer, right? Yep. Our end goal, if we think people are putting themselves at risk, however ways they put themselves at risk, or if it is interfering with their functioning, is to get them hooked up with somebody that can provide treatment. Don't think that I mean, I really believe in treatment, but I think treatment only happens when people see the need for it and are willing to try it, right? And there's a million ways people can get out of treatment. So that empathetic approach, looking at the feelings, doing some planning with people, helping people feel safer, right? Is what case managers do to do that. And also helping people recognize what are the signs. Because believe me, by the time they get to you, this is not the first time this had happened. Okay, let's go to the next one. All right, I'm going to give you guys some examples. We're going to do this as a big group discussion, unless you guys want to do it in small groups. And if you do, just say something or put it in the chat or unmute or say, no, I want to do this in small groups. So here's one. A woman moved into your housing. She has a history of psychotic behavior, but is not in treatment. She isolates almost immediately when she gets into the housing, and you've been getting complaints from the neighbors because she hollers all night. You've talked to her previously, and she's interested when you're doing a cooking class with other residents, and the property manager is ready to send him a notice. Okay. Bye, Larry. All right. You should also know that the first complaint from the neighbors is she has a bunch of people in her room and they're all having a fight. So at first I thought, maybe the isolation is not the issue. Maybe she does have people in her room. And then every time we got a complaint, we sent up somebody, we knocked on her door, and she was in there alone. So it changed our perception. But at first I thought, okay, maybe this is a different problem than I thought. So what do you think about this? Have you ever seen this? Has this ever happened? You don't have people hollering all night?
The screaming all night is the clear indication that there is some distress, whether
Yes.
that's a psychotic or some kind of
Yep.
psychosis or something else that's going on.
Yep.
Um, so that it would seem to me we need to make her feel comfortable. And if the landlord is or the property manager is saying, "Hey, here's a notice that you're first, the third one, you're at whatever the notice is saying." We also have to address her housing stability.
Absolutely.
So
So
how are these two linked then?
it's a risk, right? She's
hmm
in distress, right? And her functioning is as a tenant is being affected. So this is a priority, right? So what
hmm
do we do?
I'd go invite her to cooking class. Go knock on her
Yep.
door and say, "Hey, you want to come to cooking class?" Because,
hmm
and hope that she says yes and that there's a soft entrance there rather
hmm
than me having to
Yep.
be like, hey, we got a notice, let's talk.
So you're going to engage her, right? You're going to engage her. You're going to engage her in the cooking class. I think the cooking class is a good idea if she's interested. Absolutely. And what are we going to look for? You think she's sleeping at night?
Not if
Probably
she's
not
screaming.
well if she's screaming. Yeah,
No,
she's either not sleeping or she's having bad dreams.
exactly. So we're going to have some conversation in the cooking class. I love cooking classes because we can talk about everything, right? We're going to have some conversation about helping people sleep and what are people using to sleep. We are also going to have a conversation once she's a little bit more engaged about, well, first of all, we're going to hold the landlord off for a little bit, right? And then we're going to talk to her about, but we're going to let the landlord send a notice, right? So we're going to talk to her about you can't scream all night, right? And ask her what she thinks you can do about it. What do you think we can do? So we've engaged her a little bit. She's coming to the cooking class, right? She's talking about maybe not sleeping at night. And we're going to explain about the hollering all night, right? What the problem is, what's the issue, and what does she think we can do? So this happened to be one of my clients, so I'll tell you what happened is she said, all right, if that's the story, then I'm gonna leave the house. And this is in New York City, and it was a pretty active neighborhood, so it wasn't really dangerous. She said, I'm gonna walk around. I'm just gonna go outside and walk around. Okay. I
In the
said,
middle of
okay.
the night?
In the middle of the night. Okay.
Mhm.
Right? Okay. So she tried it. She lasted, because we were clocking her, she lasted maybe 20 minutes, right? Okay. And then she came back and she said to me, that was a stupid idea you had. Okay. So that didn't work, right? It really wasn't my idea, but okay. So what else can we do? Are you sleeping at night? So one of the things that we found out is she had a medical doctor that she liked. Talk about services. There we go. She had a medical doctor that she liked. And maybe we could talk to the medical doctor about sleeping, right? Okay. So she did eventually talk to the medical doctor about sleeping. The medical doctor was no dummy, and I had permission to talk to him. And he said, she's psychotic. I'm going to put her on risperidol. And I said, I love that idea, but I think she's going to reject that. So we talked about mental health benefits of sleeping, and he actually put her on some sleeping meds. And things got better, and she wasn't hollering all night, right? But more importantly, she trusted that this was working for her. And he adjusted the meds, he talked to her about that, the whole thing. So I'm not going to tell you a story like all of a sudden the angels sang and she went on risperidol or some sort of antipsychotic because she didn't. But it took 2 years but she eventually did, right?
Hmm.
And from her PCP, not from a psychiatrist, which I wasn't entirely thrilled with, but you know what? That's how she did it. So eventually we got there, but we solved the problem of the functioning first. So what do you think about that? You see the reason? Some people, it depended on having a really good PCP. I think everyone has somebody they feel more safe and trusted. I agree, Shania. I agree. Right? We needed to find those services. Addressing her concern helped her to get access to treatment. Exactly. Exactly. And we had to elevate that she could focus on the not sleeping. And you know what? The not sleeping was a lot more palatable as a problem to her than hearing voices.
Did you focus first on her sense of wanting to feel safe and
Yes.
not the consequence of their behavior? Like, do you also say, hey, you've got a notice here from the property management company. If this keeps up, you're gonna, risk losing your housing. Or is that not a useful to talk about the
Yeah,
consequence of the behavior?
yeah, I think it's a really good point, Matt. It's a slower process. The first thing we did was before the person sent the notice is we talked about what she liked about her housing, right?
Hmm.
So in order to understand that this was a problem, she had to identify, and it wasn't her role as a tenant, it was what she liked about her housing, right?
Hmm.
And engaged in the conversation as the way to both keep her housing and get people off her back, right? And that we use the landlord as sort of the referee in this, right? So that letting her blame the landlord a little bit about being unfair, but also understanding that these are the rules and understanding that these are the rules for other people as well, engaging her in the process of helping her feel safe, absolutely, but also doing some problem solving with her around around maintaining that apartment that meant something to her, right?
Hmm.
So first we had to establish that it meant something to her. And it was never about you're going to lose your apartment because that would scare her and would send her scuttling back to the other thing. But it was about how are you and I going to work together in helping you keep this apartment? I know it sort of sounds like the same thing, but it's not quite the same thing.
But it sounds like what you didn't do is say you have a history of a some kind of psychiatric diagnosis, and what
No,
you're experiencing is not reality. And what we're going to
no,
do is try and convince
no.
you that what you're experiencing is not real.
Exactly. And you
Mm.
know what? We eventually got to, and it took a year, we eventually got to her describing other situations where she felt scared and she couldn't sleep, and it got her in trouble.
Hmm.
And those were psychotic episodes. And look, I used to do this all the time when I worked in mental health is just say to somebody out of the blue, so what are your voices telling you, hoping they'll trip up and tell me, right? But you know what? That wouldn't work with her. And it probably doesn't work with most people. It was probably a dumb thing to do because it puts people on you don't want to put people on the offensive, but you also want to talk to people about sort of how we want to work together to help you make your life the way you want it to be. And, nobody wants to be scared. Nobody wants to be up all night. It's
Hmm.
torture, right?
Hmm.
And that's the empathy that we're going to talk to people about. And that's the thing that we're going to help them with. And as they become less scared or they don't sleep all night or they accept some sort of treatment, you can build on that. So this is about building on it, right?
Hmm.
The other thing is, look, I mean, I always thought psychosis is torture, and it is in a lot of ways, right? But you know what? It may not be people's priorities. So it's also giving her a chance to think through how this is her priority. It's gentle.
There's also so much shame and stigma around
Absolutely.
talking about mental health. And I think
Yeah.
talking about things like eating and sleeping,
Yeah.
there's not as much stigma there. And so it's like a safer conversation to have with people as you're building rapport and like getting to know them, I think, because yeah,
Absolutely.
the door can just slam. You bring up mental health. So many people have so many bad experiences being shamed, and those internal doors just kind of slam shut.
It's absolutely true. And, you know, Sarah, the initial thing about maybe put her in that cooking group, right? Gives us a chance for everybody to talk about not sleeping at night, right? And so it normalizes it. And yeah, it's one of the ways to do it. Absolutely. And I mean, we want to normalize this for people as much as possible, but we also want to normalize getting help. And that's one of the things that we need to talk about. The other thing that we did was we put a TV in a room so she could have some distraction, realizing that shelters and outreaches told us the place where she lived was really noisy. And when things get quiet, it's terrifying. So maybe that would help. And she pretty much kept the TV. We had a big negotiation on how loud the TV could be, but you know what? We got there, and that helped sometimes too. So yeah, exactly. And focus, because we were focused on sleep, right? And we were focused on what felt good to her and what felt safe to her.
She just needed some background noise.
Yeah, she need a little background noise.
Hmm.
And that works for some people, doesn't work for everybody, right? All right, let's try another one. Okay. So there's a guy living on the edge of an encampment. Come on, you outreach folks. I know you like to talk. I
Mhm.
want to hear from you guys too. Um, He doesn't want to talk to you because he doesn't have time. He tells you he owns the property that everybody's camping on, and he has to keep an eye on things. His speech is pressured. He gets agitated when you talk to him, and the other guys in the encampment are really annoyed. He tries to tell them what to do and often makes threats if they don't comply. You're worried they may hurt him. So, what's going on? What are your cues here? Okay. So, his speech is pressured, right? You want to get a little bit of the history, see if he's always like this. What we're looking for is a cyclical thing, right? Are there times when he does this, right?
Enrique, I see you unmuted. What do you think?
Thank you.
I was just gonna say that because of, the things that you were talking about before, him saying that he doesn't feel like he has time to talk to you, that his speech is pressured and agitated, while everyone in the situation seems to be a little agitated or annoyed. Um, so just a way to softly engage this man, not directly begin the conversation with, what exactly is going on. But, if he told me that he owns the property, I would kind of ask him some things about that. Like, how did that come to happen? Um, and, what's been bugging him, I guess, since he's visibly kind of agitated, if that's the conversation we're having.
There we
So,
go. He's got some leadership skills, right? Right?
Mhm.
In all likelihood, he doesn't own the property, right? But he's got some leadership skills. Give him a job or a responsibility around the camp. What was it? What's his vision for the camp, which is, I think, where you were going, right? What's he trying to get people to do? Has he had experience with this before? So we're looking for the positive, right? Is there a risk there? Right? The risk is that, yes, the other people in the camp are going to turn on him. right? So we might do a little bit of work with the camp. We might do a little bit of work with that, right? We might also talk about this is a lot of responsibility, right? And you're worried about a couple of things, like how is he moving towards housing? How is he moving towards other things, right? He deserves better, right? We're also going to monitor him for what? What are you worried about? Excuse the expression, but I'm worried he's going to get his ass kicked, okay?
Hmm.
Come on,
Yeah,
you
we want to
guys.
make sure he's safe. Make sure nobody gets mad and punches him.
Yep. Worsening symptoms, safety, yes. We also know that this is probably the most important he's felt all his life, right? He's in charge of an encampment and he believes he owns the building or he owns the property. And that it's pretty compelling to him. How likely is it to accept a psychiatric referral at this point? No, right? So we're going to focus on the behavior. We're going to try to get him to tell us a story. They call it in Hawaii talk story about when he's done this before, right? When he's been in charge of things, when he's felt like this, right? We're also aware that he's probably not going to, and then we're going to monitor him for risks for a couple of reasons, right? To try to mitigate the risks, but also we might have to use that as a leverage for him to get into treatment. We want to always offer, right? And things that he's identified, like make him feel a little bit less anxious, help him relax, those sorts of things. We can get some help with that, right? But we also have to realize that this is pretty compelling to feel like this and that we always have to monitor the risks. And we may have to compel treatment at some point in the future. We don't want to move to it too quickly, right? But because we realize that even if he gets treatment, right? We still need that relationship. We still need to work with him. We still need to help him get some structure. We still need to work on those behavioral things because treatment is going to be short-lived. That's just the reality of mental health right now, right? But we do want him to see some benefit, like maybe he slept for the first time in a while. Maybe he, right? Those sorts of things if he gets hospitalized. Okay. Is that
How do
clear
you,
about case management roles? Go ahead, Matt. Sorry.
I'm just curious how, when someone sees or understands the kind of the agitation, the frustration as a strategy that they're using to manage
Yeah.
their life.
Yep.
And when you ask them, well, what have you done in the past that makes you feel better? Going fishing, going for a
Yep.
walk, doing whatever. If that could be understood as you're trying to talk them out of this strategy that has been useful for them throughout their life to
Yeah,
manage
and it
their
could.
anxiety.
It
Because
could.
like what works for me is to get, keyed up and to like knock heads and to confront these people in the camp. That's what's worked for me in the past. And you're trying to talk me out of that strategy that I've used. So how do you manage that when what the destructive behavior is actually what they understand to be beneficial to them?
Then you talk about it as this is your strategy. I know Marcy had something, but let me just this is your strategy and it seems to work for you, but you also want to introduce, have there been times in your life when this hasn't worked?
Hmm.
And what could happen differently, right? And it takes a lot of trust to get to that point, but yeah. So what you're looking for is when it hasn't worked, right?
Hmm.
But and if you start too soon and you start to talk them out of that, like, I know a psychiatrist who can give you some meds and it'll help you feel better. The other thing to realize is that when in outreach, and you outreach providers can help me here, people are often unwilling to, and it goes with the strategy thing, unwilling to take any kind of meds when they're on the street because they don't want to be less aware. And they really are hyper focused on keeping aware, and that the mania can help people do that, right? The other thing I want to point out is we don't know it's mania, right?
Mm-hmm.
It could be a substance, right? So it's a bunch of different things. But yeah, you want to acknowledge that this has worked for them, but acknowledge it enough, be empathetic enough,
Okay.
see how that worked with them, and so they can talk about maybe some downfalls. So Marcy, you wanted to say something.
Hi, good morning. I was just
Morning.
gonna say, like we experienced something like that. We have an office. So our office building is within a tenant dwelling with 26 units. And we had a young adult who was known to us previously in programming. So we had a baseline.
Mm-hmm.
And we, experienced something with him. And I don't know if it was a first episode or certainly it was the first time that we was dealing with this. But at the height of things, they were going around to other people's apartments, like kind of just walking in and telling them that they were the smartest person that existed,
Yep.
and other people weren't on their level. And at first we're having these conversations and we're seeing this, and it was like, okay, kind of what is this? And then it was the not sleep and not whatever. So we was like up front and personal, able to like see these changes happen. And
Yep.
but it helped that we had an established relationship ahead of time because we were able to. And I always thought, like, what would this be with someone new coming in that we didn't know their baseline. We didn't know what things were like to be able to see those differences.
Mm.
And it was a lot of educating to the other tenants knew this person. They had been there, I don't know, at least 6 months or so before this happened, that they knew that this wasn't this person's typical behavior, and they were able to give a lot of grace as we continue to work and build that relationship and get them to, the right supports to be able to get them to help. But right, it was that scary thing every time we left for the day was, oh my goodness, I hope that, police aren't going to have to be, going to have to be called, or that
Mm.
people haven't lost their patience with them. Thankfully, we were able to get them to, a place where they were able to get the support that was needed. But it was a lot of work with the other tenants, and
it's
that
scary.
thing.
It takes nerves of steel, right? And it
Yeah.
takes a lot of patience. But one of the things that everything you said is great. And what I also want to say is one of the things you said is you've seen him higher functioning before. So you can help him. That's one of the things is what's the difference between this and now? And how did that feel? Was it better? Right? How did it, so that it not only helped with the other tenants, it probably, because you probably brought that into conversations, is that, I mean, this guy wants to help people. Okay, were there other times when he could help people when he was a little less charged up, right? And maybe we can talk about that, and maybe we can try to get to another level, right? But yes, having that history is really helpful. And you know what? It's the same sort of strategy when it's a new person, but you're absolutely right. It's a lot harder, right? It's a lot harder. And especially if somebody comes in manic, right? Then you're, then you're not sure, or you get called into a situation where somebody's coming in and they're really charged up. It's, yeah, it's harder. But establishing when he wasn't behaving that way, right? And he wasn't so charged up, and how that was effective is one of the ways that people see the other behavior can be helpful. It's hard. But it sounds like he's doing okay, right?
Good.
Congratulations. That's a wonderful
That's
thing.
great.
And you know what? Especially with somebody so young, because this is going to change the rest of his life. Oftentimes we get people, and it's still possible, obviously, often we get people when they've established these patterns, and it's harder, right? But it's still hard with a young person. It's actually got a lot more complications, but this, there's a lot of hope in this story that you told. He's lucky to have you. And he's lucky to have these other people in the building who were able to give him some grace. And you
Mhm.
work in that is an amazing thing.
I think the other thing we come up against is, especially with young people, is that they have a lot of kind of resistance, like family wise, where when family don't acknowledge kind of what they're going through, or
Yes.
like, and they tell them they don't need medication, like that's
Yep.
like not,
Yep.
that's not a thing, and really it really works against like what is helpful.
Yeah, and I can tell from the way you're thinking that, I mean, most younger people want to reunite with their family on some level, even if their family was awful, right? And getting that approval is really important, right?
Mhm.
But that making those decisions for themselves and the best thing for themselves can be really important. And it takes a relationship and it takes them to have some hope. That's a tough thing with the families.
Mm.
Sometimes it's their friends, right? Yeah. And we just need to deal with that and ask people like, tell us a story. Tell us a story. Has this been helpful before, right? And yeah, but it's a lot to reject for anybody, right? People want to be part of something, and being part of a family is a big part of it. Yeah, it's tough. Thank you. Okay, let's try the next one. Borderline, whoops, sides is. All right, I just want to say something about borderline personality disorder. If you see somebody diagnosed as borderline personality disorder, I want to translate for that for you. Impossible. Usually when people start talking about, oh, they're borderline, they think they're impossible, okay? But that's not completely true, right? Though I know there can be pretty dramatic things when people have that personality. There's a couple of things you should know to tune into people. Usually, people with personality disorders feel empty inside, and it's terrifying. And that they're dependent on your reactions and reactions of people around them to make themselves feel whole. The other thing is usually people have severe trauma in their histories. So remember the trauma-informed care. So we want to think about that. It is intense working with people to get a reaction. You'll often see splitting, which is Matt's example in the guy that was manic, right? Is that this might have worked for them before. The splitting is very effective, right? But we're going to short circuit that. People feel empty. People engage in impulsive or risky behaviors. They may engage in self-harm, typically engage in self-harm, suicidal thoughts, suicidal threats, intense anger, hard to control. My diagnostic for people who are borderline personality disorder is when my entire staff wanted to hold hands and jump off the roof, right? Then I knew, okay, we had a problem here. All right. So what we need to do is be united, right? Be reassuring, be consistent. We need to communicate. Everybody needs to give the same message, right? Because the splitting is not helping. Let me tell you a story about somebody who did have a diagnosis of borderline personality disorder. Is this woman was in a shelter and there were fights all day. She would get everybody worked up, the whole thing, right? And we kept trying to help her feel safer, help her feel more in control, help her, right? And that one day she had picked up her mother's ashes. Okay, so this was a shelter program for people with serious and persistent mental illness. At least half the people in that room had psychotic disorders, right? So they were all sitting around a table. She took out the ashes, she sprinkled them on her ice cream, and she ate them. The reaction was intense, right? I could see it happening from across the table, and I sort of leaped across the table to stop it, but I didn't get there in time. And she looked at me with a smirk on her face, and she said, I was never close to my mother. Now I am. The reaction from the other people in the room was nuclear, right? So, okay. This was bad, right? So we separated her out. We gave her a consistent message. We actually negotiated the ashes from her so it didn't happen again. It really didn't have to because she'd already gotten her reaction, right? And we started to talk about it. We minimized the chaos. We recognized that she was feeling empty, right? We tried some empathy. We recognized that she was trying to get a reaction from people, but it wasn't, she was trying to make everybody sicker, but she was trying to get a reaction and also show her point, right? She was very injured by her mother. We made a safety plan. We made a behavioral plan, right? We worried about self-harm. She also did some cutting. We had a structured and consistent planning process with her. We double teamed, which really helped, right? And we encouraged people to tap out, right, before they gave a reaction, both the clients and the staff. We did consistently and consistent behavioral limits from all the staff. Kind behavioral limits. And we tried an exercise with the staff before we would do a case study and talk about what the next steps were amongst the staff. We went around the room and everybody said something they liked about her. And the staff thought I was nuts. Right? So why did I do that? Why is it important that people identify something they liked about her?
Well,
Builds
kind
up.
of as you said, if this person feels hollow and is solely living off of reactions, give an example of like, okay, you can feel something. You're going to receive these compliments and you're going to see that you are more than your hollow feeling. You are a person. You are doing things.
And a lot of times when people engage in the behaviors, whether they have a borderline personality disorder or not, when they engage in the behavior, the relationship with case managers is adversarial. And the first instinct is try to control the behavior, which sets up a dynamic between them. Sometimes we didn't even talk about what we admired about her. Sometimes we did. But I wanted it to shine out of the staff's eyes. I wanted them to think about it, and people pick up on those cues. So it's some level of acceptance, and that's exactly right, Enrique. We wanted to switch the narrative a little bit. Did that fix everything? God, no, right? It was the structure, it was everything else, but it helped. It also helped staff to cope, right?
Something that you said in this instance, Andrea, is kind of interesting in that you also had to address her behavior with the other residents, the other participants in the program.
Absolutely.
And to what extent is there maybe some tension or sort of an ethical line where you have to talk about the behavior because they live in community, so it's impacting the
Right.
whole program. But you're not pathologizing, you're not talking about her diagnosis, you're just focused on the behavior
Yes.
and how people are responding to that behavior. You're not disclosing, oh, she is really, she's got this mental illness that is really challenging, and our staff are having a hard time with her, and we need your help to kind of be a little bit more gracious. Or to talk a little bit how you would approach that with other clients or other residents when they're also being impacted by the behavior.
Yeah, and is that you're right. We absolutely talked about only observed behavior, right? But we also talked about in general terms, everybody's got hurt that they carry with them,
Mhm.
right? And when you're feeling hurt, you don't always do the things that You do the things that make you feel better. You're not always aware of everybody else, right? So we talked about how people can deal with it. And actually, one of the things that happened in this group is people, a lot of people had problems with their parents, their family, everybody else. And they actually, the clients were able to make observations and help people think about other strategies that might have worked for them. They may not work for this client, but for them thinking about it in a proactive way, right? And that they were also more aware and in community with people, is that, relationships with families can be awful, right?
Mhm.
And they actually told her some stories about themselves, and she felt heard, right? It wasn't quite as satisfying as the horror that went through this group when she ate those out. Let me tell you something. I wasn't exactly a poker face either. I did one of these, no, but we could talk about being proactive, and we could talk about building empathy, right? And we could talk about shared experiences, and that's basically how we did it, is that we talked about things like hurt and how to make people understand it and that sort of thing, and how they did it and how other people can do it, and tried to get, just like Marcy said, is try to get them to give her a little grace, and also be aware that part of our job was to protect them from the things that they said. So we did a lot of planning around that. And so it came in concert with putting more structure on it. Yeah.
Okay.
And it helped. She was able to get through the program. It was not without incident, right? But she was able to get through the program. So our first instinct wasn't to throw her out.
Okay.
And people understand the whole concept of grace because everybody wants grace in their life, right? So, how do we help people get connected to treatment? Help them see a reason they want to engage in treatment. And we're going to talk about this in a minute in terms of the stages of change. People have to build trust in treatment. Their experience with treatment probably is not good. I also want to say something is treatment is effective. I'm going to talk about psychosis for a minute in treating some aspects of psychosis, but fixed delusions rarely respond, at least right away, to treatment, to medication. And those are things that we need to temper our expectations. This is not going to make it all better. We also want to help people with basics like food, sleeping, those sorts of things. We want to teach problem-solving skills. Let's talk a little bit about that timing and how we deal with this. So let's talk a little bit about stages of change, which is next. So remember this chart with stages of change? And one of the things it does is allows us and encourages us to work with people before they're ready for change, before they say they want change. So most of the people we work with, particularly around mental health issues, are in pre-contemplation or maybe on contemplation. So our job is to help people move to the next stage. So when people have no awareness of the problem with mental illness, we want to draw those parallels. We want to provide a structure. We want to be empathetic. We want to ask questions about how this interferes with their functioning. We want to make sure that the things that it's interfering with are things that mean something to people, right? It's almost impossible to talk about tenancy if people hate their apartment, right? So we're going to try to increase people's ability to see positive things about something. It's interfering with something they want, but the key is they got to want it and how they see that it's interfering. We're not threatening people to throw them out or anything, but we're talking about is, right? Though there are points when we take control. This is not what we're talking about here. As people begin to see that this may be a problem, you want to engage in a problem-solving conversation about pros and cons of changing, right? I'm not even going to go through this other stuff, but I think that this has been very helpful to me because it sort of gives you a clue about what to do at each stage and an awareness of where people are in the change process. I don't know, but in my life, people rarely change because I tell them to. They've got to see the reason themselves. And unless your experience is radically different, and I want to know your secret, then it's really going through the process with them. So I want to just reinforce this. Does this make sense? Is this helpful in any way? Okay. All right. Let's go to the next one. Let's talk about the substance use disorders. Okay. Here we go. Okay. So, most important thing. In order for somebody to have a substance abuse disorder, they've got to have recurrent use resulting in failure to meet major life obligations. So it's a functional definition. Work, home, appointments, housing, right? Recurrent use in hazardous situations, judgment, that sort of thing. Legal related problems. Consistent use despite getting all those cues, right? From the functioning. And the diagnosis matters less than the functional impact. In fact, the diagnosis is based on the functional impact. So one of the cues to helping people get treatment, if you're going to refer people into treatment, is, I don't know if you have this experience, but I used to refer to psychiatrists or somebody, substance abuse program, and I would say, yeah, they're opioid dependent. Okay, you know what? They would say to me, or they're schizophrenic, and the doctor, and then they would say to me, really? After you get out of medical school, please come back and tell me the diagnosis. But in the meantime, tell me what they're doing, right? People want to make their own decisions. So I learned pretty quick. So it's the most important to identify where this interferes with their lives. Okay, and also what are the positive aspects of their lives that this brings to them? So that's radically important, right? Because you got to know what somebody gets out of it, and as we're initiating the change process. Okay. Remember, pre-contemplation, we can ask those sorts of questions. So how does substance use often show up? Rent arrears, money going, other priorities. They have a relationship with substances, not such a relationship with tenancy. Unauthorized guests, noise complaints, unit conditions fall below standard. Yes. Right? Does that mean they have a substance use problem? No. But it means that we want to suspect it, right? Legal exposure, particularly around holding drugs. Oftentimes people will switch it. Sometimes people will switch their apartments. You have a lot of scatter site apartments. Sometimes people will let people use their apartment for drugs because they get a taste. Dealing, other activities like that. They might avoid the worker because the worker is not a priority, and they perceive the worker as somebody trying to change their behavior. And keep in mind that everybody in their life in the past has tried to change their behavior, including case managers. So I remember I was on an outreach call actually in Miami, and I said to somebody, so does housing interest you at all? Yeah, he said, I want housing. And I said, okay. And he said, and I'll quit drinking once I get housing. And I thought, So I said to him, and it really stuck in my craw. Why? He said, because I know those are the rules for housing. And I said, well, not always. Right? But let's talk about this. Do you think the drinking is interfering with it? Let's talk about it, right? But the truth is, a lot of people think that they have to pretend or not drink or not use in order to keep housing. And so sometimes how that plays out is they avoid meeting with a worker. There are also often medical complications, and sometimes the medical complications are extreme. Emergency room visits. It's rarely about substances and in isolation. It's always about behavior and the impact on tenancy and functioning. Utilities not being paid, exactly, right? It's the relationship. They're trying to maintain the relationship with the drugs or alcohol. right? And they'll make all sorts of compromises to do that, including sitting in the dark. Okay. So how are we going to deal with this? Think about stages of change. Think about how to talk to people. Think about the structure of housing, using the lease to create expectations, right? We're thinking about all of those things, and we're addressing the behavior. We're also paying a lot of attention to crisis, right? And so with all of this, behavioral health, substance, crisis takes a while to build. I also want to say, I know you guys are good at this, but you're going to miss something. So I want to tell you that I know you guys from what you're talking about are really good and thoughtful about this, but you're going to miss something. So I'm just saying right now, don't beat yourself up, right? Nobody is perfect at this, and our case management is a series of second chances. Yeah. So we want to look for the signs: agitation, disorganized behavior, threats, withdrawal, disturbed sleep, statements about being unable to keep going. We want to pay a lot of attention to that, right? We want to evaluate if this is a crisis. Somebody starts giving away their stuff or makes references to not being able to continue, you want to pay a lot of attention to that. And you want to have a policy what you're going to do when you see signs of suicidality. So we've got some guidance around doing a suicide potential assessment, but that's what we want to pay a lot of attention to, right? We don't necessarily want to confront people. Remember, their primary relationship is with the drugs or alcohol, or their primary they are engaged in continuing what they're doing, right? Or dealing with what they're doing, having coping strategies. So we want to be gentle and not necessarily confront people unless it's an emergency, and then we have to be prepared to what we're going to do in case of an emergency. We're going to ask people the same questions. What's helped in the past? What could help them feel safer now? We're going to de-escalate before the moment of crisis. We're going to be aware of things like, do people feel more comfortable if we take them out of a room? By the way, try not to do a de-escalation process in front of an audience, though it's sometimes not, right? Because that can go south really quickly. We want to help them identify the signs of crisis so they can do some crisis prevention themselves. Okay, let's go to the next one. So what do we want to do when we de-escalate? Stay calm. Watch your tone. Body language steady. It's contagious. My personal approach, oh, that's nice. My hair is standing straight on end. My personal approach is that one of the things that I do is I really consistently breathe. I get people to breathe with me. If I take a deep breath, take 3 deep breaths, right? Oftentimes people will imitate that behavior. That's a helpful thing. The other thing that I do is when somebody's agitated is I sit down, if it's safe. The other thing is I lower my voice as quietly as possible, because I want people to stop screaming to hear what I'm saying. You can validate people's feelings without validating the content of their belief. That's critically important. It's not people aren't chasing you. It's, okay, this is feeling really scary right now. How can we help you feel safe? You want to offer choices, not just one, but a couple of different choices. You want to move to a quieter space. Having an audience can escalate things quickly. but having other people around might calm the person. So you need to know about that. You want to be clear. You want to be consistent. You want to use structures that have helped before. This is the other thing. Talk to your team. So Marcy said we had history with people. You probably have some sort of history with other things, with people that are in every program, right? So one of the things you want to do is talk to people about calming techniques, what helps, what doesn't help, right? You want to also know who your backup is and who do you call and how fast can they get there. And that includes the police and the ambulance. You need to make a better plan if the ambulance is going to take an hour and a half to get there, or mobile crisis is going to take 2 days to get there. That was the turnaround in New York City for a while. Yeah, we'll be with you in 48 hours. I remember thinking 48 hours, right? So we had to make another plan. So be aware of that. Be aware of who your resources are. Advocate for better resources. By the way, 48 hours was unacceptable and they changed that, but it had to do with funding and staffing and stuff like that. So let's figure this out, right? But know who your backup is before you do this. And finally, know when to tap out. And have somebody else around that you can tap out to. If you are in a situation where you're doing outreach alone or you're going on a home visit alone, right? And things get agitated and you feel like, you're getting agitated or you're having a hard time dealing with this, leave, right? Leave and get help. It doesn't mean you don't have to go far, but get out of the situation, right? If you feel like you can't calm it down, get out of the situation. Let me ask you something. Do you guys do crisis plans? Crisis prevention plans? Yeah? Are they helpful? No? Okay. So one of the things that we did was we put together for case managers how to have a crisis prevention conversation when things are calm. Would that be helpful to you guys? Do you want a copy of it? Okay. Doesn't mean you have to follow it. Actually, what most people do is take pieces of it because they find it useful. Some people don't find it useful at all. But we're happy to show you that because I think it was really helpful to us. And it's something you may want to consider. But you want to have these crisis prevention conversations when things are calm all the time. Do people feel like you can do some de-escalating? Do you do a lot of de-escalating? Who's good at it? Yes? Marcy? Yes? Okay. Johnny, okay. One of the things that we do often in communities of practice is ask people to talk about their de-escalating techniques, and it's often much more helpful when it comes from a provider. Would something like that be helpful? Yes, no? People feel like they have it under control? Yeah? Okay. Okay.
That thumbs up was it would be helpful.
Okay. Okay. Let's do that. I already heard that you guys are really effective at it, and we've integrated some of those techniques into this, but it's helpful to hear from other people, right? And don't be afraid to talk about, a lot of the interventions I try go south pretty quickly, and then I readjust. So don't be afraid to talk about that. All right.
I've made a note to pass along the crisis prevention plan outline that we have, so we'll do that. We've got about 10 minutes left, so we need to move at a good clip now.
Okay. All right, you guys, I'm going to talk New York fast. Suicide risk, warning signals, giving away belongings, saying you won't see them anymore, losing interest in activities, making a threat, right? Self-harm. Remember, if people have engaged in self-harm or suicidal behavior in the past, it makes it more likely that they will engage in it again. And it also, the more people try, the more likely it is that they will succeed. So we need to be really careful of that. We need to know as much a history of that. And that, yeah, making references to suicide is never just talk, and that it often includes a loss of hope, losing interest in things. There's some really good trainings on suicide prevention. There's also a hotline. My advice to you is, as a program, do some training on what are the signs of suicidality and how you're going to respond to it consistently as a team. And this is going to sound heavy-handed, but our policy in our building was initially, if people made references to suicidality or they showed one or more signs of suicidality, they had to get evaluated. So pulling in clinicians, case managers can definitely do the initial suicide risk assessment. We can train on that if that's something people are interested in, but there's a lot of good material out there, and I bet your programs have some of that material. I see you, Marcy. What do you think? No? Okay.
Oh, anything would be helpful.
Okay. We're
thank
helpful to
you.
do that. We're helpful to get you some resources, and we will do that.
Do you find, I know this question has come up in other trainings, managing when there's the participant or the client is talking about suicide, and there's a sense that it might be a form of manipulation.
Yep.
That it's not, they don't have a plan, or they don't have how do you make the distinction between behaviors and talk that's something that maybe is a warning sign versus something that is
Yeah.
a form of something, a way to get
I think
attention?
that it's a complicated question, right? How do you decide whether you're going to transport somebody and their immediate risk of suicide, right?
Mhm.
I think that there are a lot of signs for that. Having a plan is definitely one of them. If they have a plan, they should be seen immediately, right? I think that, and they did plan and access to it, right? I think that, that the suicide risk assessments are pretty good at that. But I also take it really serious. If somebody is making a lot of references, and it may be manipulation, but that's fine. People succeed by accident sometimes, and we've got to take them all seriously. It doesn't mean that they're immediately transported or I call mobile crisis immediately, but it does mean that some of these risk assessments are pretty good. And we're happy to show you some. If you have ones you really like, that'd be good. But it's a tricky situation, right? And I mean, my feeling is suicide is such a big risk that we err on the basis of caution,
Mhm.
right? But
Okay.
having also a structured way to respond to it also talks people out of that manipulative. If people go through a full assessment or the pre-transport suicide risk assessment, every time they make it probably doesn't get them what they want. So it sort of weeds out itself, right? So you want to put that structure in place.
Okay.
Here's some good questions, right? Have you had thoughts of ending your life? What stopped you before? You know, do you have a plan? What are things that keep you safe right now? You can also make a safety plan with people, and that's often something that we do if it's not an imminent risk, right? But first, we got to do the assessment to see what level of risk it is, and then we tailor our stuff to that. You are often going to say, we mentioned people who have the collection of behaviors that's often referred to as borderline personality disorder. Oftentimes they are in a constant state of suicidality, and putting that structure in place is often really helpful to them, and that you want to do that assessment.
Okay.
Risk to others, self to others, how to transport people. I'm actually probably going to move this a little bit, but if somebody is at imminent risk, and imminent risk is defined about immediate, right? Is that this is going to happen immediately, not a long-term plan. Involuntary evaluation can be pursued under your state law. Sometimes a clinician can petition the Department of Mental Health to have somebody taken to the hospital. You can certainly do it through the police. By the way, If you are using the police, I'm going to tell you my big tip in building and working with the police. So we used to have to use police to take people to the hospital for evaluation, and sometimes they were great, and sometimes they were awful, and sometimes they were just okay. So we identified things that were helpful with the police, and we started writing these letters based on people's badge numbers to the precinct. And I mean, I tried everything. I went to the morning rounds. I met with the precinct captain. Didn't make any difference. One of those letters made a huge difference. So one of the things that I said is, this is where they were helpful. They talked to the case manager. They talked to the person. They tried to de-escalate the situation, right? They did the following things, and we sent it to the precinct. And it turns out that in New York City, and probably in most places, sometimes promotions and raises in the police department can be based on positive feedback from the community. And that they barely ever get a letter like that. And they were thrilled. And the next time people came, though this isn't what I was going for, everybody was like, do you have my badge number? Do you have my badge number? And so what we did was, for the first 3 months, we only wrote positive letters. If somebody was just okay, we didn't write a letter at all. And if somebody was, unless it was egregious, we didn't write a negative letter. And then after 3 months, we started writing the negative letters, but we still didn't reward the sort of okay behavior. And then the behavior gradually changed because we were very specific about what we were looking for. And the letters were the most effective thing we did. So we need to get systems to respond to us. So that's just a clue. Every state has its own civil commitment process. Check with your agency. We always want to try to make people voluntary as much as possible. That's all the work you've been doing as a case manager. You know, understanding what are the problems, understanding what are the triggers, that sort of thing. Overdose, suicidal ideation, or homicidal ideation should always be seen by a medical or behavioral specialist. But as Matt said, if the risk is imminent and if you're at this point, you can't get the person or provider voluntarily, that's the moment to escalate to your supervisor and crisis services. Okay. These are some crisis services. You know about these. Connect to statewide crisis services. Meet with a BH link, right? Okay. Ask in advance, what's your typical response line? We want to advocate for people to have access to these crisis services. So in the most stark terms as possible, that these programs are built to fill a gap. The program that you're running is built to fill a gap. It is not built to provide the services that other people are being paid for. So it is, we want to pursue. And if people are not responding to you, please write the specifics to Sarah so they can help you advocate. Also talk to your agency, talk to your, administrators if you're seeing patterns where these agencies are not responding to you. But remember, they are being paid for this service. You are not. Okay. These are some basics. I'm going to let you review these later. Like when working with the police or EMS, what do you do? Having these written down so people know what to do and it's consistent is really important. Crisis intervention team officers are really important. I'm not going to go through this. You can take a look at those. You can take a look at those. The case studies. Maybe do them in your team meeting. Tell me what you think. Okay. We're going to talk about this later. I'm not going to go through this, the housing crisis prevention through lease structure. I think getting that, how to have a conversation about a crisis plan would be more important to this session. So we're going to give you that. We will pick this up at another time because we're out of time. Okay, here's some resources. I just want to put a plug in for this modified mini screen. It was developed out of SAMHSA, Substance Abuse Mental Health Services Administration, and it's a way that people can self-diagnose. We've used it as a tool a lot. It can also help you get some guidance about what's going on with people. Take a look at it. The training materials that are attached to it are actually pretty good. So it may be useful to you, but it gives you an idea in broad categories what people are experiencing so you can appropriately refer. Okay. It also, people have used it as a basis in PATH programs to qualify people having a mental health disability. It can also be used by clinicians who can diagnose as a quick way, particularly on outreach, to get people that disability screen. These are other behavioral health resources, certified behavioral health clinics, safe stations. Those are things that are available to you. You need to have your own resource list and also pay a lot of attention to resources that have been helpful to people in the past. But these are more general resources. Okay. So I'm going to wrap it up. This is the Housing Innovations team. Feel free. Email us. Great. Yep,
And
Derek said that many Rhode Island police departments have CIT, crisis intervention trained teams. They can be really helpful. The training is really good, actually.
all right. We have 2 more trainings in our series, and then we'll shift to the community of practice, but we're going to talk about housing stabilization and eviction prevention in our next 2 trainings. So I am ready to jump in. And I know that we had to kind of fly through some of these materials at the end. So we're going to send out these slides along with some of the resources that we talked about, the crisis prevention plan, the suicide risk assessment, and the slides so that you have everything. And if you want to practice some of those scenarios on your own, there's some guidelines in the comments section of the slides to give you some hints about that. So we'll pick things up in 2 weeks. Appreciate everyone's engagement, and
You guys, it's always a pleasure.
you guys are great. Yeah, it's a good group. We appreciate it. All right, till next time. Thanks, everyone.
Thank you.